My job here is to talk about really our experience in the physician group practice demonstration. I'd love to talk a lot more and at greater length about what we did at Billings Clinic, the details of some of our quality improvement projects, our efficiencies, et cetera. When I looked at the time frame, perhaps we can do that more in the panel discussion and get into the details. But I think that our experience in the PGP is something that is timely. Everyone is interested in ACOs. We're awaiting the final rules. And so I think that there's some details about that journey and our interaction that I need to share with you. So I ended up putting some of our observations on clinical integration, some of our clinical improvement vignettes, the details of that into an appendix, which are included in your resources. So I'm putting that off in hopes for the better good, perhaps. A little bit about Billings Clinic. Billings Clinic was a for-profit partnership of multi-specialty group practice of over 75 years duration. And in 1993, before the advent of the expansion of imaging, outpatient surgery, and the like, we recognized at that time that we were on the cusp of a change, that we either had to pursue that as a clinic and, in essence, gut the local hospital, which is across the street, or look at things a little bit differently and create a different model or vision so that we actually merged with the community hospital and created a not-for-profit foundation model, if you will, an integrated system where physicians became employers or employees, but also leadership in the new organization. It allowed us to organize our clinical care, create a single patient bill, invest in a single electronic health record, and start having a single and shared vision for the community and for the region. We are a single hospital, 272 beds, level 2 trauma center. It is the tertiary referral hospital for the region. Interestingly, we have a strong competitor in town, a Catholic hospital, St. Vincent's, which is also part of the same organization that owns St. Mary's in Grand Junction. And so we have some interesting comparisons. But we also manage and support 7 critical access hospitals in our region. We don't own them, although over time I think that we're going to be having closer relationships and maybe equity ownership in some of them. We have a board of directors. Back in '93, the IRS told us we could have 20% of the board could be doctors. And we haven't changed that, even though the rules have changed. What we emphasized was the internal board, very analogous to the Mayo Clinic's Board of Governors. That is a majority of physicians, and those physicians have to be full-time practicing. They're elected by their peers, and that's where a lot of the organizational decision-making does occur. This gives you an idea of our service area. It's primarily the eastern 2/3 of Montana, the northern half of Wyoming, and we go into the western Dakotas a bit. This is how big Montana is. On your USA Today, on the front page, it shows you the density of, except for Alaska, Wyoming and Montana are the lowest density population states certainly in the 48 states. But if you put Montana over the map of eastern United States, it includes both Chicago as well as Washington, D.C. So we have big challenges. We certainly do a lot of outreach, like 80 outreach clinics a month, physical outreach, where we fly or drive to. And then we do a lot of telemedicine, So let's get back to the physician group practice demonstration, which really is the Medicare Alpha ACO. These are the objectives. The notion was that perhaps a organized group can get their arms around both Part A and Part B, because it's like a balloon. You press in on one side and it bulges out the other, and how you get your arms around that. The timeline for it was, in essence, 2005 through 2009, although it was, the base year was calendar year 2004. The performance years were offset by a quarter, and it ended in March of 2010. Here are the groups and where their location. It actually was a mixture. We had some very pure physician group practices, Everett and Marshfield clinics, integrated delivery systems like Billings Clinic, St. John's in Missouri, Geisinger, Park Nicollet in the Twin Cities, Novant Forsyth in North Carolina, a couple of academic medical centers, Michigan and Dartmouth Hitchcock, and kind of a unique group, which really was a PHO in a sole hospital community provider town in Middlesex, Connecticut. So the demonstration concepts were that it was really based on reducing the rate of growth in the per capita expenditures for improving quality. During that time, Medicare Part D came out, and we didn't add that to the mix. But it was a pure shared savings model. Fee-for-service continues, and then CMS shares the calculations. Now, the individuals were individually risk adjusted. The attribution was by the plurality of office visits, not any of the other visits that might have, but it was all specialty, not primary care. And so for us, it figured in a lot of our outreach clinics ended up garnering patients there for us that were attributed to us, even though they lived 300 miles away and we didn't have any primary care in that region. It was looked at after the fact. They went back and retrospectively identified these patients. The absolute threshold for demonstrating savings was 2%. The sharing was 80%, but it was only on savings that exceeded the threshold but were less than the cap. The data feedback was intended on a quarterly basis, but it really broke down over time. And there were 32 quality measures with a shared savings gate, a quality gate of about 50%. So graphically, this is what it would look like. Anything that they deemed over a 2% savings, they kept 20% and shared 80%, but based on a quality gate that in year 3 to 5 was 50%. ACO rules, proposed rules, is a 100% gate. These were the quality measures, and in discussion with CMS, we convinced them that we really ought to do this gradually over time, roll them out sequentially, and that's exactly what we did. And these quality measures were clearly all outpatient. It was around chronic disease states. It was the appropriate quality measures. At the time, it was where the evidence-based medicine could establish this. Interestingly, the quality targets were both relative or absolute, so that it was a benchmark of either a 10%, greater than 10% improvement in the gap each year, or a absolute mark of 70% of HEDIS measures or Medicare average. These are the information for Billings Clinic, but I think that I can speak for all 10 groups in that these were really basic strategies for reducing cost, and that was focusing on the high-cost areas. Clearly, the notion was that you avoided these admissions, ER visits that lead to admissions, and that was the big bogey. 40% of all costs were in the inpatient arena. And then focusing on chronic care and prevention, and so that, interestingly, the financial savings were inpatient-driven, but all the quality measures were outpatient. These were some of our patient focus areas, and those circled are talked about in the vignettes in the appendix that I gave you in your summary. all of the groups either had electronic health records in place or they were developing them at the time. We had an electronic health record clinical workstation, which we shared similar to Intermountain Healthcare, but unfortunately 3M went out of the business. And so we had to start all over again in 2004, late 2004, and we had to implement a whole new electronic health record during that time. I would advise all of you to have it in place before you join an ACO. Certainly an EMR allows you to do the disease registries that Craig talked about to allow at point of care a reminder of what needs to be done at that time of visit to ensure that all of the quality measures are met and better care is given to our patients with these chronic conditions. It allows for understanding health maintenance that needs to be done, and it also allows for optimal patient, or rather medication reconciliation during transitions of care between hospital and the ambulatory setting. Well, let's look at the outcomes. It's over. It's been over for over a year. I actually can't tell you year 5 results. I can't actually have them written down, although I'm going to probably verbally tell you a little bit about them, because this is part of the process of the delay that CMS seems to be challenged with. There was a discussion yesterday. The Norton group talked about how when they push out a quality measure or a process improvement, a clinical improvement plan to their providers, it actually is applied to all groups, those that are part of their HMO and those that are not. And what we found universally among all 10 groups is we were working on improving care for our Medicare population, which is, you know, a minority of our ambulatory patients. We actually found that some of the same improvements were applied equally to all of our commercial patients, et cetera. Clinicians bridle at the concept that you're going to provide a higher level of care to one part of their patients than the others. They're very egalitarian in their approach, and I would say that you have to recognize that you start down this pathway with one carrier or one payer partner, and it's going to end up improving the care and maybe the cost efficiencies for other payers. For the first time, at least at Billings Clinic, we started focusing on population management instead of just the patient that happens to darken our door. And also understanding that there are a lot of gaps in care in our chronic disease management. Now, the following are just some examples from the physician group practices. The first two actually apply to Billings Clinic. We were able to create a program that reduced heart failure hospitalizations by 40%. And so by doing that, we ended up over those 4 years, or those 5 years actually, reducing our own revenue by $4 million. And it cost us about $2 million to do. So, you know, and the only thing that limited us is we just limited it to 15% of the heart failure population. We could not afford to actually do that for all of the heart failure population and still survive under a fee-for-service environment. We were able to reduce one-day psychiatric hospitalizations by 20% by creating an alternative approach toward hospitalizing these patients. Many of the groups universally created planned visits, what they call max packing a visit. If you come in for a visit for hypertension, making sure that everything is done for that patient during that day. Improving access so that emergency room use is down, and then chronic disease management using nurse lines for anticoagulation and for heart failure, for lipids, diabetes, et cetera. And then risk stratification for complex patients. I mentioned the EMR optimization. The quality measures actually require custom in order to capture it in your EHR, they require custom programming to be able to capture that at point of care and put it into a reportable field. And that really does point out the fact that you have certified EHRs, and I'm not sure what they're certified to do. They certainly aren't certified by my standards in terms of helping primary care physicians take care of chronic disease patients. And I'd like to have the ONC understand that. Clearly, all 10 organizations had significant quality improvement. In fact, they were pretty high quality organizations, but they didn't, they improved even more. Now, in terms of the actual dollars, here you see through year 4, Medicare will tell you that through year 4, they saved, the savings were $97 million. But in fact, I can tell you that that's above 2%. In fact, you can take the 2% threshold. You can also factor in any organizations that lost money during that time. And actually, the real number is over twice that, almost twice that. It's about just under $180 million through year 4. And so the true sharing is far less than 50%, not 80%. One organization captured over 50% of the total. So if you take them out, you really wonder what the benefit is over the other organizations. The total 4-year savings payment reflects 2% of net patient expenditures for Medicare for all the organizations. So we're dealing with very tiny percentages and amounts. For most, the savings that they identified or were able to be paid on was far less than the reduced revenues and the business costs of implementation of these measures. And so the ROI, I think, at least in this demonstration, was not present, except for one organization. Risk adjustment was significant in the factor. Quarterly data was difficult. And we found that there really was not true patient engagement that occurred as a result of the demonstration. It was only our own efforts because there was no attribution. The patients really didn't know. And that's what they want to continue in the ACOs of the future. A couple of observations. 6 of the 10 organizations made bonus. Billings Clinic was not one of them. But only 2 actually did consistently. And one organization had 50% of the payments. What was interesting is that that same organization had the same percentage growth in attributed per capita expenditures as Billings Clinic did. And yet, we were not in the money. And a lot of that goes with the fact that you had 10 groups and you had 10 comparison, not a unified comparison, not a national benchmark. And it was based on percentages, and we'll talk a little bit about that. I can tell you verbally that in year 5, there actually were fewer. There were only 4 organizations that made, and they were new organizations. A couple dropped out, and a couple new came in. Very interesting details that occur at year 5. The growth in Medicare Advantage in these individual markets had an impact on the 5 years, so that the patients shifted. There was ongoing change in attribution because of the shifts in the market. For Billings Clinic, risk factor growth and maintenance we found were really hard work. We were able to actually reduce our per capita expenditure between year 4 and 5. We actually were able to go negative. And yet, because there was no rebasing, we were already in a hole and we couldn't demonstrate any savings for the entire program because of the lack of rebasing. This gives you an idea of the distribution of the 306 hospital referral regions. And you can understand that if you're basing the benchmark on a percentage of growth, then if you are in a low cost area, then percentage of a low number is a low number, and a percentage of a high number is a high number. And so there were particular challenges that you have in a percentage or rate-based benchmark. By the way, Billings Clinic, which is at the bottom of that distribution, that's in that same row as with Grand Junction. You're in that same one. So let's compare the PGP demonstration of the ACO proposed rules. I know they're proposed rules, and so I don't want to spend too much time, but I do want to point out a couple of things as you think about the future rules. No lock-in or enrollment, retrospective annual assignment, that is in essence in both. There's a difference between all specialty and primary care. A big difference in terms of being able to, I think in primary care you're able to actually predict who your patients are. What we found using the PGP method is that only 62% of fee-for-service Medicare actually got assigned, and that was the range in the 10 groups. On the primary care method, utilizing a simulation model of we actually did simulation and actually worked with CMS over the last year prior to the proposed rules coming out. And they used a lot of our data and our input to do some what-ifs that allowed them to make some decisions that ultimately they obviously changed in the proposed rules. But if you use that primary care assignment to the PGP, you actually came up with an 80% assignment. So using the same data, it's a much higher assignment level, and a lot of the E&M visits are captured. Now, when I say primary care specialist, that's what's listed in the ACO rules. Those are the codes that are assigned on a UB4 or 1500 form that are specialty specific. What's interesting is that PAs and nurse practitioners don't have a specialty specific code. And so there's no way that CMS and the PACO system can differentiate between the two of them. And that needs to be fixed. Population risk adjustment. How many people here know the risk score for their fee-for-service population, for their Medicare fee-for-service population? That's what I thought. We don't either. That's a problem. And I think that that's something that you need to understand because in the ACO rules, they basically fix that at the base. There's no risk adjustment during those 3 years of the ACO demonstration or performance year. HCCs are based on the diagnosis codes, and the average is around 1, and specifically tied to 1. There's an importance of specificity, the 4th and 5th digits used in the ICD-9 code, and the completeness, which is important when you're doing making problem lists and also submitting claims. We did an audit of our internal medicine department. We found that only 50% of the visits, and 50% of the visits to an internist, complex patients generally, they only put down 1 diagnosis for that visit, even though when we looked at the charts, it was obvious they were being taken care of. They were handling their diabetes, hypertension, lipids, etc. But they only put down 1 diagnosis because that's all you have to do in order to get paid. But it seriously affects your risk score. And if every per capita expenditure of every individual is risk adjusted, if you really have a generic codes that you're submitting, your HCC scores are going to be much lower than 1 and much lower than the national average. As you build registries, it's important that you don't just put in a generic code for diabetes because you're going to dumb down your claims. HCC rules, or the proposed rule set, is that it's set at growth for the base. And so there's no further growth according to the proposed ACO rules. We'll see how they come out of that. I don't think a lot of discussion has occurred around that area. As far as the target, going from the rate of growth to something that the PGPs had a very, very definite impact on the Senate Finance Committee language in the ACO provision of the PPACA. And that is that the target is actually the national fee-for-service per capita actual dollar increase each year. And that then keeps the low-cost areas in the game because they can see an upside. And it still keeps the high-cost areas in the game because they have a lot of fat to cut. So that's the notion. The timeline, this is a slide from the American Hospital Association that talks about the timeline and the weighting of the different benchmarks. But this also is your timeline for creating your HCC risk adjustment for your population. So you can get working on that right now if you're interested in the ACO. The threshold, I think your slides have an error, and for the PGP, they only recognized savings over 2%. CMS kept the first 2%, and then 80-20 of anything over 2%, and a cap of 5. You know, in the ACO track 1 and 2, there's a 7.5% cap, a 10% cap for track 2. It sounds much more attractive, but I can tell you that all the organizations, only once out of those 5 years was a cap ever instituted at 5%. So, and that was the most successful organization. So it's unlikely that a cap means anything in the Medicare fee-for-service market. Losses, of course, in the PGP, there really weren't any losses per se. They were carried forward in the determination. So if you had a loss in a first year, then you had to grow out of that. But there's a true loss in both track 1 and track 2 in the ACOs, and a lot of criticism has been made to CMS about that. The fact that a shared savings program has suddenly morphed into a shared risk program. And I think that I predict in July when they come out, there will be a track 0 where there will be a clear shared savings only. Quality measures were only 32 in the PGP. We figured in the PGP groups that the average cost of implementation of a single measure in terms of creating the custom coding plus developing the processes around capturing that were about $30,000 per measure. And if you're starting from scratch with 65 measures, then you can do the math. The ACO quality measures, I think, appropriately expanded the quality measures out of just the ambulatory outpatient arena that were only in preventive health and at-risk populations. And they've added the inpatient issues, the core measures from a hospital side. They emphasize care coordination and transitions of care, patient safety, as well as patient experience. It turns out that the 32 measures that are in the physician group practice make up domain 4 and 5. And so all of those measures would just make up about 40% of the quality measures in terms of the actual scoring. There's a list of the proposed ACO quality measures in terms of their domains. And as you see, in some of the domains, there are fewer numbers of measures, And so each of those measures is more heavily weighted as a result. You don't have all 65 equally weighted. And that's a continuation of the quality measures. Now, we know that there is an add-on or an incentive coming from CMI of talking about the Pioneer ACO model. And that is for mature organizations who are probably already taking risk in the commercial sector because of this curious notion that CMS is actually describing that by the end of year 2, 50% of all of your business needs to be some outcomes measures. Now, they seem to be a little bit more flexible as to what they describe as outcomes measures. And it could be a pay for performance or some quality improvement processes that you already have in arrangements with your commercial payers. But that is one consideration. Billings Clinic actually could not be considered for the Pioneer model, in part because of we really are in a fee-for-service environment. Our commercial payers are not very sophisticated or yet willing to do a lot of risk-based or even shared savings, although they express interest now. So we would be kind of eliminated as a result of that. There are also a minimum number of beneficiaries, and it's interesting, depending upon your market, what kind of MA penetration is, and analyzing it from the primary care point of view, we still would be about 1,000 short of 15,000 in the fee-for-service market, and that may actually continue to decline as more of our patients are signing up for MA programs. Risk adjustment is important, by the way, with that trend, because MA plans are signing up the new 65 folks, and a lot of the chronic and chronic disease patients, the patients who are the sickest, seem to stay on in fee-for-service Medicare, and so their risks and their expenditures are going up compared with the MA plans. This is an estimate by the American Hospital Association that they've published. CMS looked at the PGP groups, and they came up with an idea that it cost us about a little under $2 million to invest in and start up our PGP demonstration. I can tell you that for Billings Clinic, the ongoing operational work is about $4 million a year to do what we were doing, and we weren't doing as much as we really would like to, and we would love to reinvest savings into better infrastructure to do more for our patients. I don't think that the figure for a single hospital system of 66.4 million or for the larger 5-hospital system of 14 million is off base. With our physician group practice, all of us had a single tax ID number. We had governance structures. We could accept an analysis right off the bat. In order to create that kind of an infrastructure, and I think that Lee can probably further comment on that as he has invested in developing the advocate system. Even without the ACO, it's a significant investment. Well, this is a slide about data sharing from Medicare. And I want to tell you that you might think that woman is actually checking out her makeup, but she's actually driving the car, looking through the rearview mirror. And that was how all 10 of us groups felt in the PGP demonstration. Because the data that came to us was indecipherable. We did have a few organizations that had a better statistical group that could actually extract information out of the data they gave us. But again, it was very late, and it wasn't something that you could drive a car by. So this leads to what we're doing next. And in fact, all 10 groups in the PGP are currently in a demonstration. It started in January of this year, and it's going to go for 2 years. So all 10 groups have signed up. And you don't know anything about this because there hasn't been a press release, and I'm already violating an embargo policy. But I'm going to tell you that if we're 6 months into a 24-month program and they want to embargo the fact that they're going to announce that this has occurred, I just don't think they're holding up their part of the bargain, and I don't feel bad about not holding up my part of the bargain. We are in a transition demo, and I won't go into the details of that, but I would say that it's probably halfway between the ACO demonstration and the PGP. We have primary care attribution. We have measures that are about 45 measures in between and various other things. We have a national benchmark that's similar to the ACO provision. Now, what's interesting, I'm thinking about that, two of the groups, the two academic medical centers, actually were able to choose the all-payer or all-specialty attribution instead of the primary care attribution. They were given a pass to actually use the old attribution. Because when academic medical centers frequently look at primary care attribution, they don't have a good enough primary care base to successfully look at this. The University of Michigan, I can't remember what their attributed population was in the PGP, but it was significant, but under primary care attribution, it would drift down into about 17,000. The University of Michigan, only 17,000 in primary care attribution. And a lot of it depends upon how that AMC is structured. So I was looking to the AMCs as being a leader in the ACO movement. But unless there's some adjustment of that, they're not going to be coming to the table, I don't believe. So what we're going to be doing at Billings Clinic for the transition demo, we're going to be trying to nail health home, our medical home, redefining our roles and incentives. We've already salaried our internists so that give them some room and freedom to breathe while they work on the really expanding the medical home. And understanding how to involve specialists who care for patients with chronic diseases, like our pulmonologists with COPD and our heart failure patients with cardiology. We need to invest more in our financial side. We've invested a lot in our clinical information system to the detriment of really understanding our cost structure, our ability to do cost accounting, so that we can understand how we can squeeze costs out of the system and increase value. We're working on our payer relationships with our commercial group and risk assumption, talking about bundling payments, et cetera. And this is how we envision the ACO. And at the center is the health home. This goes with, and is very consistent with Paul Grendy's approach, is that when he was talking about medical homes many years ago, and then ACOs have come out, it's just one end of the tunnel versus the other. And I think I think Premier Incorporated uses this model diagram, this cartoon, that this is how that it's really the health home. All of the other providers provide to that health home, that the ACO provides the leadership in the IT and infrastructure, and that helps promote that and keeps that all together, and that you have to have a willing payer partner in order for this to actually work. My thoughts on why primary care or a patient-centered medical home has to be the center of an ACO is that it encourages prevention, it encourages this relationship. In other words, the cognition and relationship over the technology. It means that the patient with the low back pain can go into their primary care physician, and because of that relationship and that knowledge, can accept the fact that a conservative approach without imaging is appropriate for that patient without radiculopathy. And if that patient had sought care primarily at the orthopedist or neurosurgeon, they undoubtedly would get imaging, they would get some other tests, particularly if those people had owned their own magnets or EMG machines, et cetera. I mean, you know that they're going to end up using them. And, but if the orthopod told them they didn't need an imaging, that really wouldn't work because they don't have a relationship with them. And so just like the notion was, who is the shooter's doctor? I think the implication is that doctor of the shooter should have recognized the development of this schizophrenia that eventually was at center of the motivation for that shooter. I think that primary care, the medical home, is where you can have less variation in utilization. It's clearly how other organizations or in other countries have made sure that healthcare is half the cost in midi-modern nations, is half the cost of the United States simply because you access your care at the primary care level. This is a notion about primary care and the medical home where it has to be team-based, because basically you can provide excellent access so that patients feel like when they need you, they can get in to see you. But it may not be the physician, it may be your team. And for simple things, it's the mid-level or even the nurse. Why a physician has to take someone's blood pressure and follow up with essential hypertension and adjust the management and not by the nurse under protocol. We all know that physicians like those easy visits. But in fact, that physician could be doing, supervising the others, could be following up on chart reviews proactively, doing telephone outreach, mail outreach, responding to a lot more patients in a given day than he or she could if they were stuck with the tyranny of the visit. So the challenges and lessons learned, clearly we need to become more efficient in our care. Healthcare is woefully inefficient. There's so much muda around that you don't know where to start cutting it out. We have to start focusing on populations, not just the patients that darken our door. That this is the work of medication reconciliation, care management, the transitions. Doing it right the first time so that we don't have waste of redo or rehospitalization starting all over again. It clearly requires leadership and organizational capacities that we're going to require both physicians as well as hospitals coming together to create these organizations, and that IT has a central role, particularly in terms of creating tools for physicians to use. I think that in order to make ACOs work is that the attribution really does need to make sense, that those who coordinate their care need to be those who are involved in the attribution. I think that prospective is clearly the way to go, although Medicare is politically stuck on the freedom of choice, I believe. That's how you engage patients in the chronic care model. It calls for an engaged patient, and if you don't know who that patient is, and they don't know who they are, then how can you engage them? The risk adjustment needs to be in place to secure provider confidence against reverse cherry picking. There needs to be a comparison group similar to what I think is now appropriate in the ACO rules, a national goal. The performance threshold needs to be a stretch but attainable, and I think that we need to have first dollar sharing in order for it to be meaningful. And I think there needs to be quality measures similar to what Greg has mentioned, a concentration on the things that really matter and not by bulk. And it would be nice if these quality measures were actually harmonized between Medicare and Medicaid, and between Minnesota and Florida, and between the Blues and other commercial insurers. But I think that shared savings as a long-term design is really, it's a transition. Shared savings is a, I don't know, a 6 to 10 year play. It's a way for us to go from fee-for-service, paying for volume, to paying for value, and somehow getting us there. As Don Fisher had mentioned yesterday, the problem that our organizations face is we've got 1 foot in fee-for-service and 1 foot in the ACO model working toward perhaps capitation or global payment, and how to keep our organizations afloat during those shifts is really the big concern of most of our organizational leaders. So this is, I think, the bridge from fee-for-service to accountable care. And this is Island Lake. It's a short drive from Billings, up in the Beartooth Mountains, and this was taken by one of our internists, and so not a professional photographer. So no questions now, but questions later. So thank you very much.